First of all, thank you for being here. Thank you for having me. I cherish the opportunity to speak in front of all of you a bit of the topic that I am passionate about most. It's refractive laser surgery. And today I'm going to speak about the limits, so some indications, but also limits of refractive laser surgery and the decision-making associated with it. So a few words on my behalf. My name is Viktor Ruff. I'm senior clinical expert at Zimmer Ophthalmic Systems, and I have a bit more than 5 years of clinical experience as an optometrist in the refractive surgery field, accompanying doctors and working alongside optometrists in refractive surgery, doing diagnostics, refractions, and accompanying them at the laser. So I know the diagnostic tool chain as well as the lasers associated in refractive surgery. And for now more than 9 years, I have collected experience in applied R&D for surgical lasers, both femtosecond and ablation lasers. And since 2022, I've been project manager and senior expert for application of the ablation laser Aquarius, which I helped to co-develop and made the first clinical steps with at Zimmer Ophthalmic Systems. Now let's dive straight in. First of all, I'd like to lose a few words on what is this laser I've been working on. So its name is Aquarius. It's not an excimer laser. And I just want to mention it does use laser crystals. Sorry. Oh, I'm sorry. Something happened to the presentation. I'll be right back. So for some reason it crashed, but
you just need to share it again, Viktor. Just click share.
To share it again, but it was really the PowerPoint crashing. So this is something I encountered for the first time.
Get back to Zoom.
Yeah. So then here we are. Now we should be back.
Yes, it's loading back. Good. We see it.
You see it, and I should be able to navigate. There we go. Yeah, so I was speaking about the Aquarius, which is a solid state laser and not a gas laser. So it's using laser crystals instead of gas to produce the laser energy. And this it does at a specific wavelength of 205 to 215 nanometers, and thereby enables wet ablation process on the cornea, which is somewhat special as it enables a gentle tissue interaction. This is the product I'm working on. But now let's dive straight into the topic. Indications and borderline cases of refractive surgery. Now, refractive surgery today has evolved to something that is really close to perfection. It delivers very good results. And over the last 30 years, we could really see this development live as technology involved, the associated laser technology, the eye tracking technology, and the treatment algorithms. They all have improved to contribute to a better accuracy and predictability and reproducibility in patients. And what we see now is that all those treatment options that are available, LASIK, PRK, trans-PRK in terms of ablation lasers and lenticular extraction for femtosecond lasers, they do deliver excellent visual outcomes for the majority of patients, but they have to also appropriately be selected. And by the way, I'm always mentioning those references here. So there is a final slide also where you have some of the literature which I'm referring to. Now, learning about excellence, first thing we have to understand, it's not equal to universality. So there's the saying that goes, if all you have is a hammer, every problem looks like a nail. And the bottom line is not every patient, not every eye benefits from the same correction strategy. And therefore, that's what I frequently hear when I'm working together with doctors is that they regard their refractive tool chain as a toolkit, in fact, where each tool offers a specific solution for the patient to optimize the result in the individual situation. Now, it is in fact a spectrum of options. So we have laser-based procedures. We can use LASIK and PRK. We can use lenticular-based procedures, implantable lenses such as IOL and phakic IOL. We can go for contact lenses, or we can combine all of them. But always with the goal in mind to optimize the functional vision, to maintain safety, and to maintain a long-term stability for the patient. Now, we'll look at two particular cases today, one of which is high hyperopia, and the second one, a myopic case, and then we will conclude on that. Starting first with the high hyperopia is certainly something beyond the typical comfort zone of a refractive surgeon. Now, what I've understood is that some of you, in fact, do refractive surgery or are associated with refractive surgery here. So I hope that you will also find something to take away from this presentation as well. Now, what we know in hyperopia, the indications typically range up to +6, but in some cases, higher treatments were reported in case reports, or even small-scale feasibility studies. So LASIK was reported up to +8 with fairly well results, and KLEX, lenticular procedures such as CLEAR and SMILE, have been performed up to +7 diopters for hyperopia. And we see it's in fact feasible, but where do we draw the line? Where do we draw the borderline? Now, taking this example case of a 50-year-old patient, at the time he wanted to see whether he can have LASIK, and he came with a refraction of spherically +7 on the right eye with -2.75 astigmatism, and on the left eye with +625 with -1.5 astigmatism. He had fairly good vision, 1.25 on both eyes. Unaided vision was good as well, since he was able to accommodate. And looking here at the K values, we see that the flat Ks are somewhat in the normal range. The steep Ks are on the steeper side, already beginning to be on the steeper side. And then looking at the topography, of course, we want to see that the topography is regular, that the tomography is regular, and we don't see indications of foam thrust keratoconus that would drive us into an ectasia risk. And what we see here is an oblique astigmatism, also pretty much in line with the astigmatism axis we found on a manifest refraction. We also see that both anterior and posterior elevations are have no special features, looking pretty normal. The pachymetry is thick enough. Also here, no indications whatsoever that there may be something wrong with the cornea. That looks nice. Similarly, we have to look at the left eye. We have some artifacts on the posterior surface here, but this is probably from the coverage of the eyelid. But also here we find a pretty normal situation. Now, all in all, we will ask the question, okay, will we do refractive surgery on this patient? And then there goes an old strategy to first calculate the case that you would end up with. So the curvatures post-operatively. And this you do by applying some calculus. First breaking it down to Jackson cross cylinder, doing the same for keratometry, and then subtracting them from each other. And what you end up with is a residual K of close to 50 diopters on the flat meridian of both eyes, and exceeding 50 diopters on the steep meridian of those both eyes, averaging 50 diopters for both eyes. And why? Because we are treating and ablating in the periphery here to steepen up the cornea. We want to correct for the plus. Now, this 10 years ago would have been a clear contraindication. There was a general rule that everything above 49 diopters of postoperative curvature would lead to problems, and this has been revised. So this is not a hard cutoff factor anymore, but in fact we do need to make some special considerations for this case, and we need to make it fit perfectly. So both the flap and the optical zone center need to be aligned on the close to the visual axis, meaning by the first Purkinje reflex. Now, the optical zone size needs to be chosen large enough, larger than 6.7 millimeters, to prevent regression to happen. We know that regression is associated with big curvature changes in the periphery. The further we stretch this out into the periphery, the less curvature gradient we risk in the periphery, and the less we trigger the epithelium to grow. Now, what we have to bear in mind is that most laser systems will add a large transition zone from plus 2.5 to plus 3 millimeters in radial dimension. So we need to squeeze all of that in onto our treatment area, and we need to center everything nicely onto each other. And summing it up, we need to remove tissue peripherally, and this is very sensitive, in fact, to optical zone size, transition zone size, as it is directly linked to a risk of regression. The decentration is a topic where we need to particularly have a look, because, as it will induce higher order aberrations and also coma. And the 49 diopter criterion, as it was shown in literature, is not the actual correlate to the worst visual acuity that was found in many of high hyperopic corrections that were treated having a bad outcome, but it's rather linked to the magnitude of correction. And there is still research going on. I recently spoke with a doctor that the epithelium mapping may help guide us here on the hyperopic ablations. But still, as you see, this remains a corner case, a very complex case, something not very easy to do. And the bottom line here, you should think twice what you do, and before you do that in a patient, and you must carefully weigh the patient expectations with the associated risk. And you may bear in mind that there's other treatment options for the patient as well, for, let's say, a time until other options are open. Now, the second case, a myopic case, is subscripted knowing when not to laser. So here we will look at particular red flags. Now, we know that refractive stability is one key requirement for any success in refractive laser surgery. And we do have to know that we correct the current refractive state, and we do not by any means alter, let's say, if there's a progression going on. We don't alter the underlying mechanisms for this progression. And this is why we have to particularly take care that in young adults, we look at exactly this factor. We look at the myopia progression. It may look stable in the short term, but we need to also see it on the longer term, whether progression is still ongoing in a patient before treating the patient. Now, when we still perform LASIK on such an unstable case, we of course risk that we have to do an enhancement, and we will end up having a not very satisfied patient. And I guess this is what we all want to avoid. And this is where we can make an excursus, because refractive surgery is, this is what I want to depict here, basically equals expectation management, because eyes do change with time, and an excellent outcome doesn't mean it will last forever. It doesn't mean it's good for one particular visual goal, may it be reading or night driving. So this is what you need to bear in mind and manage your the expectations of your patients carefully. Now, progressive myopia clearly is a red flag. And we know it from literature and from the most indications for most laser systems that the typical cutoff, the borderline, is 0.5 diopters per year. That is considered as clinically significant progression. And now, even though the cornea may be looking normal, topography looks normal, this continuous myopic drift may have an effect on our predictability of the treatment we plan. And we have learned that it does increase the likelihood of post-op regression and just a re-enhancement cycle that we don't want to run into. Looking at a 20-year-old patient now with small myopia, this is a patient that came in to apply for laser eye surgery for LASIK, started or came with a -225 on the right eye, cylinder of 225, and -2.5 on the left eye with -125 astigmatism. Now, CDVA was pretty good, 1.0 in both eyes, slightly better. UDVA was as expected. And topography, of course, we looked at that. Also here, pretty normal with the rule astigmatism, nothing special on the anterior surface, nothing special on the posterior surface, and also the thickness map looked pretty normal. And the same thing we saw on the left eye. So nothing particular here, but the moment the patient drew out her old prescriptions, we saw that there was glasses back from 2019 where she had a -125 in sphere, slightly lower astigmatism, okay? And then there was glasses in July 2020 where the myopia was already slightly higher. On the right eye -175, on the left eye -2. So we see some progression going on here. And now we have to judge, is this a borderline case or can we still treat? And in fact, looking at the manifest refraction spherical equivalent, we see that maybe for the first period, when you break it down to a 12-month change, we are slightly below this hard limit of 0.5 diopters, but already for the second term between July 2020 and the day of the exam, September 2021, we have 0.58 diopters of increase of myopia. And we have that documented, right? We have 2 time windows with documented progressing myopia. So this is clearly a patient that we should think twice to treat. So you can decide either way to laser or not to laser, and then you will end up either with sunshine or with rain in this case. But you can think for yourself what would be the best strategy here. So the bottom line of today's talk, refractive surgery can deliver excellent results, and it does it. And we keep pushing those boundaries of refractive surgery. We are working and developing better systems to increase safety and predictability of those. But as a surgeon, you need to choose your refractive strategy. And the refractive strategy you choose best according to the needs of the patient, to the associated risk scenarios, and in the borderline cases, you may find that even the best technology comes at its limits. So what I want to give you as a takeaway here, do your patient selection carefully, manage the expectations of your patients carefully, rather under promise but then over deliver, and choose from a toolkit of refractive tools, from a full tool set and not only from a single solution. Remember the hammer, don't be the hammer, use the full toolkit. And that was about it. I have here the literature list for you. I can send it around if you like and make it accessible for you. But this was it with my presentation. Thank you for your kind attention.